We're going to move into our next session that will focus on a project that we're really excited about, addressing critical emerging issues in COVID-19 and transplant recipients. And this session is kindly sponsored by AstraZeneca and GSK, so thank you very much for that. Rienk de Vries is a patient partner on this project and will be the moderator for this session. So I'll start by introducing Rienk. He lives in Oakville, Ontario, and runs a consulting firm that has provided services in the water industry for more than 15 years in Canada, the US, and the Caribbean. He's been a patient partner with CDTRP Theme 5 for a little over a year. He had a heart transplant in December 2012 and has been involved in a number of transplantation-related research projects over the last 10 years. Well, over to you, Rienk.
Thank you very much, Patricia. And so I'm a little bit nervous today, so just bear with me. It's not because of this conference, but Holland is about to kick off, and I was born and raised in Holland. We're playing Argentina, and I just noticed Brazil lost. So I was kind of hoping for that next game to be Holland-Brazil. But so if you see me kind of sneaking a peek, I may be watching what the score is. But the reason I'm here, and I think it's really important when we look at this research that's coming up, I think it sort of pulls a lot of the things together that we've all been talking about for the last 3 days effectively. So we have a very nice panel. I think a lot of them are online, so I don't know if we can bring them up on the screen. And so when I introduce them, you can see their pictures on the screen. And each of them, you know, I've been doing this for about a year now, and I realize there's so many people here that have been doing this for, you know, since 2014. And it's a real privilege to be here. I'm excited. I'm really excited that as a patient, we are starting to have a voice. And believe me, when I had my transplant, so it's in 2 weeks, it'll be 10 years since I had my new heart. And at that time, we had no voice. And so navigating through the medical system is a very, very tough task. And I have means, I have privilege, I have education, I have connections. Most people don't. And so I'm humbled by the fact that I'm able to stand here. I feel great. And so thank you very, very much, because the reason I am standing here and enjoying life is because of all the work that everybody does. Promise won't talk anymore. With that in mind, the research that we're planning here takes all those views into account. And so, and I don't know where we're at in terms of the submission, but hopefully, you know, Patricia will update us on that. So, and the people that have been working on this from the various perspective are the ones you're going to see here on the panel. So I'd like to introduce each of them, and they can maybe wave. Is Dr. Mucsi, and I've worked with Dr. Mucsi on a number of projects, is a clinician investigator and transplant nephrologist at the Multi-Organ Transplant Program and Division of Nephrology at the University Health Network in Toronto. His current research focuses on understanding and reducing barriers and disparities in access to kidney transplantation, and reducing and living donor kidney transplantation, and assessing the impact of psychosocial distress on clinical outcomes of kidney transplant recipients. And again, an essential part of what we're trying to get at. Dr. Dima Kabbani on the screen there is an assistant professor in the Division of Infectious Diseases at the University of Alberta. Her clinical focus is infections in immunocompromised host. She is the education lead for the Transplant Infectious Diseases Fellowship Program at the University of Alberta. Her research includes the epidemiology and outcomes of infection in organ transplant recipients, and more recently, response to COVID-19 vaccines in organ transplants. The patient partner that I've been working with on this project is Sherrie Logan. She's the founder of Ashley's Angels, a third-party fundraising initiative supporting the transplant program at the Hospital for Sick Children, which she formed following her daughter's liver transplant in 2009. Sherrie is a patient partner with CDTRP, a Society of Pediatric Liver Transplantation, Patients and Family Engaged Partners, and Starzl Network. Recently, Sherrie became co-lead of the Exercise Hub Theme 5 that I'm involved in as well with CDTRP, and is pursuing a master's in public health at the University of Alberta. And next we have Dr. Caroline Piotrowski. She's an associate professor at the Department of Community Health Sciences at the University of Manitoba. She's also a scientist at the Children's Hospital Research Institute of Manitoba and is founding director of the Violence and Injury Prevention Research Group at the University of Manitoba. Her areas of research expertise include sibling relationships, trauma and resilience in children and families, and post-traumatic growth. And then finally, on the economic front, we have Dr. Kednapa Thavorn. She's a senior scientist and scientific lead of health economics at the Ottawa Hospital Research Institute. She's also an associate professor with the School of Epidemiology and Public Health at the University of Ottawa and an adjunct scientist at ICES. Her research focuses on health economics, health technology assessment, pharma epidemiology, I'm going to get these right one day, health equity, care for people with complex needs, and population health. And so each comes at this from a very important perspective. Typically, you know, people focus a lot on treatments, medication in working with trying to respond to crises like COVID-19 or any kind of crisis that we might have in healthcare. And so we very quickly go to that side of the ledger. As a patient, we look at this very differently. We're trying to live healthy, happy lives. And so there are a lot of other elements that we would like to focus on. One is the mental health aspects. And again, Dr. Mucsi spent a lot of time trying to figure out how do we take a balanced human sort of centric approach to research. And same on the sort of economic front is there's an underestimation in terms of the impact that a lot of these sort of journeys that we go through as patients that they have on our lives. We may not be able to work, but no one's kind of focusing on that. And so as a society, how do we really focus our research on outcomes for patients? And so, you know, we feel like we've been trying to say, hey, what about us on the end of the line? And it's too late because everything's already defined, everything's already designed, everything's already in play. So it's really important as we listen to each of the panelists and say a few things about their perspectives, that we look at all these perspectives in all the research that we do. And so again, Sherrie and myself, we really appreciate that we have a voice. And we have our expertise we can attribute, and someone's listening. And so it is a big deal. So with that, I would like to start on the presentation. So Patricia, you're doing first.
Yeah, I'll start. Thank you. Thank you so much, Rienk, for what a wonderful introduction to this project. This project is really a wonderful example of what CDTRP as a national network can do with the expertise in so many different areas, responding to patient priorities and building a large national initiative together using all of our skill sets. So this project started, I alluded to this in the year in review when we started this meeting. In March, we held a national forum to understand what the community felt the research priorities were in COVID. Now, there's no one who wants COVID not to be a thing anymore than transplant patients. But unfortunately, that's not where we are. So we brought together patient partners, researchers of multiple disciplines, including economics, including public health, including infectious disease, as well as frontline clinicians who are seeing issues, in their practice, and brought them together to set out priority research questions in 4 different areas. So what are the best uses of emerging agents, antivirals and monoclonals? How can we be faster? How can we develop a pathway to understand new therapeutics or prophylactics that are in development, do the research on them specifically in immunocompromised in transplant patients, and do that fast enough so that the knowledge that we gain from those studies is still relevant by the time the next variant comes out. How can we do that? And then lastly, from the patient and family point of view, what are the most important questions for recovery and long-term well-being and helping people get back to normal, whatever that is? And these are the three sort of topical areas that came out of that discussion for priorities. The first one is specifically around treatment timing. So at that time, sotrovimab was the main therapeutic in use, and the therapeutic window, of course, is quite fixed. So this was thought to be a really important issue if that was also applicable to transplant recipients in the same way. What are the real costs, qualitative and quantitative, of the policies, not just COVID itself, which is important to understand, but the public health policies that impact many aspects of patients' lives, mental health, the quality of their physical health, and their stress in an inability to return to their normal. And then lastly, it's great to understand those issues, but what can we do about them? What supports are currently required in different aspects of patients and family life that can support them? So then we followed up that priority setting session with a session led by Sherrie and Rienk at our Patient, Family, and Donor Research Forum held in June. And I will pass it over to Sherrie to talk about the results from that.
Thank you so much, Patricia. So I'm going to share a little bit about what we discussed in the CDTRP Patient, Family, and Forums discussion on June 23rd. And I think it's important to make sure we date this so we know exactly the information revolves around timing and pandemic. So the very first top left pie graph, you will notice, I like to refer to this as we are in this together. So we polled the participants. There was 22 patients and researchers were involved as well. And caregivers involved in this poll. Several of the studies that we've examined in mental health impacts comparing transplant recipients and their families members to the general population, including during the initial pandemic lockdown, the results indicate that there are positive findings from the transplant community, including less exposure, a sense of belonging to a community residing under the same population level mandate, and an opportunity to adapt to new social and medical virtual settings. Some of the concerns during this stage were medical interruptions and severe outcomes, and that remained throughout the whole pandemic. The second graph that I'd like to point your attention to is on the top right. I consider this a shift to you are on your own. So this is speaking particularly during the waves of COVID pandemic. So with the lifting of the pandemic lockdown, social networks disappeared with the return of in-person activities. Additionally, as subsequent protective measures lifted, it resulted in an increased risk of COVID-19 exposure within crowded indoor spaces. New systematic barriers created within the potential political shifts had and continue to have significant costs, causing severe stress, anxiety, and other mental health issues, reduced quality of health, and an inability to return to pre-pandemic activities for patients with comorbidities safely. The bottom graph that I'd like to draw your attention to, which I like to refer to this as attempting to adjust with uncertainty in a divided community. So this particularly we looked at, on June 23rd is kind of how are we feeling at this stage? As we enter this new phase of the pandemic, the transplant community is now facing not only the virus, but increasing stigmatization and trauma of feeling abandoned by their communities because of the need to maintain health precautions that the general population is leaving behind. This shift from we are in this together as a community to you are on your own has created a divide between transplant communities and the communities in which we live, work, learn, and play. As transplant recipients attempting to adjust to pandemic-related shifts in policy, receive delayed or interrupted clinical care procedures, process contradictory messages with insufficient guidance, and to manage our new and uncertain realities, the pandemic and social constructs are continuing to cause psychological distress on this community. Next slide, please. Emerging research indicates that many transplant recipients and their families are experiencing a disproportionate amount of psychological distress and reduced quality of life during the pandemic. Even before the onset of the pandemic, Adjusting to life after transplantation encompass struggles and hardships for caregivers, family members, and the transplant recipient and our family function. Uncertainty, ongoing and constant fear of infection, rejection, graft loss, need for retransplantation, medical complication, and death play a traumatizing role in the post-transplant journey for transplant recipients and their family members. According to many studies, up to 50% of pediatric caregivers experience mental health symptoms, including post-traumatic stress disorder, and transplant recipients experience similar rates of anxiety, depression, and sleeping disorders. Furthermore, these challenges have been greatly exacerbated by the pandemic for the transplant community. 30 patients and caregivers at the forum that we polled identified their greatest challenges in mental health during the pandemic as ongoing anxiety, fear, and depression, information overload and a lack of tools, social isolation, unpredictable changes in policy and government and healthcare policy, family impacts, and disappointment and anger. Next slide, please. So we took a look at, kind of the different social determinants of health. So basically, who is this affecting? What type of supports are needed? Where we can find these supports. So the COVID pandemic has impacted all aspects of society, but poses added risks to specific individuals and populations with underlying social determinants of health who are at risk and high risk. So individuals at risk of acquiring COVID-19 include people with poor or crowded living conditions, geographic issues with rural versus urban, employment, educational, financial, or transportation barriers to social protection and health services, weaker safety nets, or stigma. Individuals considered at high risk of severe short and long-term outcomes related to COVID-19 are older adults, individuals with an underlying medical condition or disability, immune-compromised, unvaccinated, poor or homeless people, marginalized ethnic minorities, or migrants. Next slide, please. Some of the quotes that we thought that we'd highlight, and there were many, but here are the ones that I think that were a good representative of our group. One was feeling forgotten by political and health leaders, angry about not being able to see family who are dying, overwhelmed by bad information, scared to venture out, feeling alone, and that I do not belong to society anymore. Next slide, please. This figure, as it is small to read, but provides an overview of commonly reported factors organized within layers of influence at the structured, community, social, and individual level on behavior, impacting the mental health and well-being of transplant recipients and their families. Additionally, factors of discrimination, such as racism, sexism, classism, intersect multiple unfavorable social determinants, leading to an increased risk of COVID-19 morbidity and mortality. Therefore, upon examining the underlying social determinants for solid organ transplant recipients, our community is considered high risk and at risk due to, at minimum, being immune suppressed and utilizing ineffective protective measures aimed at individual responsibility, respectively. Furthermore, intersectionality within this subpopulation adds intersecting layers of characteristics that influence the burden of an individual or subpopulation experience at a given time within our society. Next slide, please. And I'll turn it over.
Yep, Dima, go ahead, please. Oh, you are muted, Dima.
Thank you. I've been doing this for 2 years and I still have not learned. So before I start, I'd like to share with you actually an amazing news that we just heard earlier this week. So at the same time that we were applying for Health Canada, we submitted this proposal also for the University Hospital Foundation at the University of Alberta. And with myself, Dr. Laurie West, and Dr. Catherine Burton, with the amazing help of Patricia and Dimitra. And we just heard this week that our project got funded. So hopefully we can start this project as soon as possible. So that's exciting. So in the coming few minutes, I'll just discuss the Thank you. I'll discuss the first aim of this project, and it's to assess the efficacy of the different therapeutics that are being given for our transplant for early treatment. Next.
Yeah. Before you get in, this is I should have spoken to these, Dima. Sorry for I was too excited to get into the content of the research. I was going to speak to this slide as an overview of the whole project. So we had the studies 1, 2, and 3 objectives listed up there, and we are bringing those all together with a trial design that's a national prospective registry. So we're, as Dima mentioned, we've got some startup funding to get going at the U of A site, and I'll share some additional news on funding at the very end, but we're hoping to start recruiting patients in the spring. And our eligibility criteria is you have a transplant. So all patients will be eligible to participate in different aspects of the study depending on their particular situation. On the economic front, the burden for households or for the healthcare system, for therapeutics, for those who have the misfortune to be infected with COVID, and for the mental health component for patients, family, and caregivers. So how do we react quickly to, as I alluded to in the introduction, respond fast enough that information is useful for policymakers and those who develop clinical guidelines? And the system that we're proposing is this prospective approach, setting up a national data platform, and then at the same time, doing regular prioritization forums with a broad representation of the community to decide what the critical questions are at that moment. And then we have the data in the platform that we, with the help of methodology expertise, Tim Ramsey and his team at the Ottawa Method Center, we can respond in a much shorter time frame with the data that we have in that platform. So we hope that will speed the process from question to results and get those results in the hands of the people that need it. So here is our national team made up of researchers in 5 different provinces across the country. And of course, our patient and family partners who have been a part of this project from the very beginning. Now it's over to you, Dima, to get into the therapeutics component.
Great, thank you. So the first objective is to assess mainly the therapeutic and effectiveness in our transplant population, and also look at the effectiveness of prophylactic with monoclonal antibody in our transplant patient. And so in different, during the pandemic, we've used different treatment modalities to treat our patients, from monoclonals to antivirals. And we wanted to compare the outcome with these different therapeutic. And we will be enrolling adult solid organ transplant, pediatric solid organ transplant, and allo stem cell transplant within their first year after transplantation, or if they're on immunosuppression for their graft versus host disease. Next slide, please. And so for The objective one, which is study one, we will be collecting clinical information. So in addition to the demographic, their vaccination, the numbers of vaccine, if they get infected, if we can know the subvariant that they're being infected with. And we will look at the primary objective would be hospitalization or death after SARS-CoV-2. And we'd want to look at secondary objectives such as graft function, rejection, renal dysfunction, and cardiovascular event after infection. And study 2 and study 3 will be explained later. Next slide, please. And so this is a busy slide, but this is our thought about who we're going to include in this registry that Patricia was talking about. So we're going to include all these transplant patients, whether they've had COVID infection in the past or they've not had COVID infection, if they're recent transplant or a remote transplant. And these patients or solid organ transplant and BMT will be followed for up to a year after, or depending on when we start. And clinical data will be collected at enrollment with mental health and long-term wellness assessment. And the same informations and updates will be collected every 3 months. And if someone from this cohort gets a new SARS-CoV-2 infection, then we will follow them more closely initially, and we would continue to collect mental health and clinical information on these patients. In addition, sorry, I forgot the economic assessment that we will be collecting. But what's nice is at the same time we're including our transplant, we're going to include family members in their registry, so we can compare some of the mental health in not just our transplant patient, but our family members and their caregiver, especially if they're pediatric SOT.
So I take it over for now, talking about one part of the second section of this study, which is assessing mental health and quality of life and physical symptoms in patients and also in family members and caregivers. We will do this with using standardized questionnaires, patient-reported outcome measures, and specifically focusing on for the adult participants in this study, we will be using tools developed by the Patient-Reported Outcome Measurement Information System, which is for short PROMIS system. These are tools that are standardized and also can be referenced to the US general population average, so we can see the differences compared to a large general population. However, in addition to collecting from patients and caregivers, we are planning to collect a nationally representative sample in Canada using the same questionnaire, so we can have a national standard and we can compare the data that collected from patients and family members and caregivers to the national sample. So we will monitor physical symptoms and also emotional symptoms and mental health issues that were mentioned here as key priority, and anxiety, depression, sleep problems, social participation in a standardized way, and both regularly for people who are participating in the study and they are healthy, and also more closely when there is an infection which happens. And the second part that we'll be taking this system to the next level, hopefully, we will be doing a pilot study locally at the University Health Network using the same questionnaires, the patient-reported outcome measures, in a platform that is built already at UHN. We will be using this integrated into the electronic health records there. We will be monitoring these parameters regularly in patients with transplants. And we will have a response system. So if someone has high level of anxiety, depression, sleep issues, or other concerns identified by these tools. We will be able to discuss that, and if that goes beyond the limits of the immediate transplant care team, we will have additional tools and resources to refer the patients to. So that it will be a pilot study to assess the feasibility and acceptability of this system for a subsequent larger effectiveness trial. So that's the PROMS part, the quantitative part of this subsection of the study. And I hand it over to Caroline.
Thanks, Istvan. It's a tag team, this particular slide. Thanks very much. And just to follow up with that, for the caregivers of the pediatric solid organ transplant patients, we also have a standardized tool called the Psychosocial Assessment Tool, or PAT, which has been used for many years. It's been piloted here in Winnipeg with kidney transplant families, but it's been used extensively with families affected by pediatric cancer and lots of other chronic illnesses. And it assesses 7 domains of family functioning, including the caregiver, the affected child, healthy siblings in the family, and it gives us an overview of whether that family is considered low, moderate, or high risk for continuing issues. So that's also part of the PROMs for caregivers of pediatric patients involved in this study. I'm also going to talk a little bit about the qualitative component here, because we, of course, want to hear what both adult and pediatric transplant patients have to say about their experiences. So the goal here is to, at the same location, do some focus groups and whenever possible, individual interviews as well, to find out more about their perspectives, meaning adult transplant patients, caregivers of pediatric patients, and where possible, pediatric patients themselves, their perceptions of facilitators, barriers, and gaps in resources that may help them deal with the negative impacts of the pandemic on their mental health. And based on their responses, their wisdom, their frustrations, their concerns, their successes, the things that have worked for them, the things that have not worked for them, try to find out more about communication strategies that they felt were helpful, that they felt were successful, that we might then be able to use in a pilot as part of a coordinated communication strategy to help families access the information that is useful to them and access it in a timely manner. And that's it for me.
Yeah, over to you, Kednapa.
Thank you. So for the third objective, as Patricia related to, so we're looking at economic burden and also the value of therapeutic and pre-prophylaxis for COVID-19 in transplant patient. Even though you see 3 objectives here, but it's actually divided into 2 key components. So the first component is looking at economic burden in terms of the burden to the healthcare system, and at the same time, the burden to the society as a whole. When I'm talking about society as a whole, meaning that we're capturing the cost that are borne to the government, and at the same time the cost that borne to patient and their family member as well. And this information will really helpful to actually generating as the data as to the registry, in which it could help inform rapid response to any future question. And at the same time, it can help inform objective 2 and 3, where what we want to do is actually evaluating the value for money of existing therapeutic or prophylaxis intervention for COVID-19 in terms of for transplant patient. And at the same time, for anything or any new treatment or intervention that in the pipeline but haven't been approved, we can also using mathematical modeling and economic modeling approach to actually try to work backward and looking at what would be the minimum efficacy of that particular treatment needed to achieve in order to ensure that when it reaches to the market access where it's ready for reimbursement decision, it's turned to be cost effective or offer good value for money. all of these package will actually leverage the existing information we collect from objective 1 and 2, and all of this going to answer the question about economic burden, value for money, and at the same time, the affordability of existing and future therapeutic intervention for COVID-19 for transplant population. So that's all from my end.
Thank you very much. So I will just conclude on the or give an update on the funding situation for this project, and then Rienk will wrap it up with closing comments for the session. So we are, as Dima mentioned, we are absolutely thrilled to have about $200,000 from the University Hospital Foundation in Alberta to get going. The backbone of this project, we've been working very closely with Health Canada to understand what resources might be available from them. They issued a directed call to CDTRP to undertake these types of studies in the summer, and so we submitted our proposal to them for $1.8 million. So that's currently under review. We've also been actively seeking additional sources of funding that we need to bring this project to life. And so I'm delighted, hot off the press, too new of news even to get it on a slide. We are absolutely thrilled that AstraZeneca has provisionally approved a contribution of $300,000 to contribute to set up the data platform. So thank you very much. I can't say... I can't say, enough thanks to the work of Shauna Abel and Rodney as well, our medical liaisons with AstraZeneca for working with us and talking through the science and options. And we really appreciate your support in putting this all together. So, Rienk.
Thank you, Patricia. And I mean, it's really important, and from a patient perspective, I mean, it's just kind of news to me. I haven't been to any of these sessions before, and it's incredible. My head is exploding with information and thoughts and ideas and all that. But I think that there's not enough of that sort of available. People are not even aware of some of these things, and when you go through the journey, and for me as a heart transplant, people had lots of transplants. It's a very interesting journey, and the language that you're faced with is so different. And we've talked about that many times. And I have to tell you a couple of stories. And one is walking into Toronto General. And I spent a lot of my days there. I was a regular visitor. I had my own bed, it seemed like. But because I was waiting for a transplant, and so you're trying to stay alive, and there's this whole part of the process. But for 17 years, my heart was deteriorating. I have it's called desminopathy, a missense mutation of the desmin gene. So it's a hereditary thing. And so you kind of can map when you're going to die. You know, and as an engineer, you're mapping all these things out. And it's a really bizarre process. But then you're thinking organ donation. I knew I needed a heart transplant for quite a while. When you walk into Toronto General, right, when they talk about donors, and this is a funny word, they're not talking about organ donors. They're talking about money. So when you walk in, I'm going to use you, Leonard, in a second, but when you walk in and you see a bank of elevators, there's the Peter Monk, the Monk elevator sort of bank of elevators. And so the focus is so much on the money that I feel, despite the fact that the balanced scorecard that's used to communicate how well the hospital is doing has one pillar called patient-centric care. Right? But as a patient, I'm going, are you out of your mind? No one's talked to me, because their idea of health is financial health. So when you see your plaques on the wall, it's about Peter Monk and Mr. Gilgan and Mr. Monk, and because they're extremely important. They've handed over $40 million. I'd like to see, that's my vision of the future, that we have an elevator bank that says Sandra Holdsworth. The elevator bank, you know, because it's about changing the conversation to what healthcare is all about. And I think that now having somewhat of a voice, Leonard, I was going to use too, you can have an elevator bank too. Leonard is a living organ donor. He's a donor. So is Mr. Monk. I think once we get that sort of concept at an equal level, we've achieved what clearly, Lori, you've set out to do for a long time. And I think, and I wanted to share a kind of more personal experience to bring that home, is why are we doing, why am I standing here? Why is everyone sitting here? And ultimately, so what I'd like you to do, I know this is kind of sappy, I'm sorry, is put your hand on your heart or wherever you can feel your heartbeat. Because, and the reason I'd like you to do that is because, and if you can feel your heart, so for 17 years, I was on 98% pace on 5 different pacemaking devices. As I was deteriorating, I couldn't hear my own heart anymore. What happens is the way it paces, it doesn't react the same way with your body. But when I woke up after the surgery, so I got a heart from a young man in Nova Scotia, a whole bunch of stuff happened. They took out my old heart, put in his heart, and this thing runs like a train. But when I woke up, so I was lying on my pillow, and when your ear's on the pillow, you hear sort of an echoey sort of thing. I woke up, and I was probably still under the influence, but there's this ba-boom, 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 ba-boom. And so we all sit here. I'm very, very lucky. I was convinced I could calculate that I was the luckiest person on earth. So whenever you're doing research or you're developing policies or clinical practices or any of those things, the real outcome that we're looking for is that it's life, it's quality of life. The reason that I'm standing here is because this heart is beating inside me. When I'm on a treadmill, I can see the reaction to the work that I am doing right on the screen. My heart rate goes up, my heart rate comes down. It is unbelievable. So if you're ever doubting the things that you are doing in research in any of these areas, please don't doubt anymore. I am very, very grateful. We've all had difficult journeys as transplant recipients. And so, but at the end of the day, it's all about life. So let's not talk too much about morbidity, mortality. Let's talk about quality of life. Let's get everything out of it that we can. Let's jump around like Manuela, with all that energy. That's what we'd like to do. And so, again, I wanted to thank everybody. And the research here, the reason that Sherrie talked first is because that's the need. That's what we're feeling. That's what we're stuck with. COVID or no COVID, it's just the way it is. And so, and then everybody else sort of talked after that. We're going to solve that from all these different angles. I love all research to be focused on that. And we would all love that. So Sandra, everybody else, I love the fact we have a voice, and I really, really appreciate it. I think we all do. So with that,
we have 3 minutes left. So we could take a
question
or comment maybe, if anybody has one.
Comments, questions, people that would like to help. Do you know different people that would like to be involved in the study? Any comments? Lori.
Powerful words. It's just, yeah, I can feel my heart. And happily you can too now. So this project and the way it grew came out of the kind of framework that we've been striving to build for 10 years. Nimble, flexible, fast when it needs to be, responsive to calls that come out, but with creative outreach into the community, helpful partners who work on our behalf. And that's kind of not just Shauna and helpful funders, but the power of a community to come together quickly. And we've seen that in the pandemic all over the place, but for us in our particular field, in this particular country, the power of a community to actually say, here are the needs, here are the priorities. This is what we're getting, especially from the powerful voices like yours and the others who are most affected by this, which is our patient voices. And, I keep listening again to the fact that much as we sort of in healthcare say we want the patient voices, hearing that we're not getting them adequately much of the time is really very important. And so we really need to continue to empower the conversations that will not only help us set priorities, but really generate the new knowledge and move it forward in ways that are helpful. So thank you very much for those comments. That's really very helpful.
Thank you. Any other comments? Anybody on the screen? I can't see if there are any questions there. Tom.
Thanks for that. If I could just riff off of what Lori just said, it just struck me that one of the things that CDTRP could and should be doing is actually releasing patient position statements on a very regular basis. You know, having the voice of patients getting together, speaking about topical issues, because they don't listen to us, the physicians, they listen to you guys, and having patients, us enabling the patient voice and getting that in press releases and that kind of thing. I think it's actually a really powerful way to get into the public domain where this partly needs to be, what it is that our patients go through, what it is that they need, and the types of things that they actually need to get.
Thank you. Istvan?
Just maybe one aspect of this study that I would like to emphasize is that it's patients and families. And it's families and caregivers also for adult patients, because an illness, a condition doesn't only affect one person, it affects the unit, and actually multiple units around that tight unit that is the patient and the immediate family members. So I think one of the important aspects here is that we will be involving patients and their family members and caregivers and try to listen to their joint voices. And it's going to be important to have that participation from both patients and the families.
Thank you, Istvan. I'd like to, at this point, we're out of time. So I'd like to thank the panelists, everyone on the screen there. Thank you very much for your contributions. I also would like to thank Dimitra and CDTRP. I know there's a lot of work that went on in the background, and some of the people that you might not see. And they might have been dancing away last night, but outside of that, they were working their tails off. And I just, again, I really appreciate being invited into this conversation and to be able to work with all these wonderful people. So thank you very much.